All right, let's get straight into it. If you're an MRCOG candidate or a frontline clinician working in obstetrics, this high-yield explainer is designed specifically for you. We're going to completely unpack the RCOG Green-top Guideline No. 64. Our goal today is to distill the really vital, life-saving ward wisdom you need to confidently identify and manage maternal sepsis. We're talking about taking these clinical guidelines and translating them directly into decisive, rapid action on the labor ward. To really grasp the absolute gravity of this topic for your daily practice, just think about this number. Sepsis accounts for an astonishing 11% of all maternal deaths worldwide. That is a massive figure. And here in the UK, the MBRACE's reports keep reminding us that while we've definitely made strides, maternal sepsis remains a leading and, crucially, an often preventable cause of maternal mortality. A lot of this comes down to suboptimal care, specifically delays in recognizing those early signs. So this demands our absolute vigilance. Our roadmap for this explainer is broken down into 6 quick sections. We'll define maternal sepsis, look at the pathogens and risk factors, recognize the red flags, go over key investigations, break down the urgent management and antibiotics, and finally wrap up with fetal and neonatal care. Okay, starting off with Section 1, defining maternal sepsis.
So what exactly are we dealing with here? Well, crucially for your exam prep and your daily practice, the 2017 WHO definition completely shifted our perspective. It aligns maternal sepsis with the adult population definitions. This means the focus is shifted specifically to infection-induced organ dysfunction, rather than just the systemic inflammatory response syndrome, or SIRS. This is a game changer because, as we know, the normal physiological changes of pregnancy often mimic SIRS anyway, making those old criteria pretty problematic. Now, organ dysfunction is the key, usually measured by an increase in the SOFA score of more than 2 points.
Now, here is a classic diagnostic trap, both in your exams and on the floor, distinguishing standard sepsis from septic shock. Septic shock is a whole different beast. It's defined by persistent hypotension that actually requires vasopressors just to maintain a mean arterial pressure of 65 millimeters of mercury or more, alongside a persistent serum lactate over 2 millimoles per liter, and that's despite adequate volume resuscitation. Once a patient hits these criteria, mortality risk just spikes dramatically. Which brings us to Section 2, pathogens and risk factors. You need to know exactly what bugs you're hunting. There's a stark contrast in risk profiles here. While E. coli and Group B strep are super common, often tied to urinary sepsis or prolonged rupture of membranes, you absolutely have to maintain a uniquely high index of suspicion for Group A strep or gas. Pregnant and recently pregnant women face a staggering 80-fold increased risk of invasive gas up to 28 days postpartum. It's incredibly aggressive. And of course, if there's any history of MRSA, that totally changes your empirical antibiotic choices right off the bat. Moving right along to Section 3, recognizing sepsis red flags. On the ward, you have to instantly differentiate between your moderate risk and high-risk patients. Amber flags, things like a heart rate between 100 and 130, or a respiratory rate of 21 to 24, require a senior clinical review within 1 hour. But look at those red flags. A respiratory rate of 25 or higher, a systolic BP dipping under 90, or a heart rate shooting over 130. These are glaring, high-risk indicators that mandate immediate action. You either initiate a sepsis bundle right there, or you execute a blue light transfer if you happen to be out in the community. And look, the MBR report highlights a really important non-physiological red flag. Never, ever ignore a patient's intuition. Repeated presentations to a GP, a community midwife, or popping up constantly in obstetric triage. These are officially classified as diagnostic red flags. If a woman keeps telling you she feels unwell, you have to take it seriously, evaluate her thoroughly, and actively rule out sepsis. Okay, Section 4. Key investigations and monitoring. Literally, sear this number into your brain right now. 4 millimoles per liter. While a lactate of 2 or more should definitely kick off a senior review in IV fluids, a serum lactate of 4 or higher is a definitive, undeniable sign of severe tissue hypoperfusion. This threshold means you need immediate escalation of care, and it should trigger a direct, right-now discussion with your critical care team. This ties perfectly into the official RCOG recommendations, which cement the absolute mandate to use early warning systems that are modified specifically for obstetrics. And why is that? Because pregnant women have this incredible ability to compensate physiologically, right up until they abruptly crash. The window for early detection is terrifyingly narrow. That's why monitoring via a maternity-specific early warning score paired with immediate multidisciplinary escalation is quite literally a lifesaver.
So what are your essential investigations once you suspect sepsis? Before you push any drugs, you really want to grab 2 sets of blood cultures, an aerobic and an anaerobic bottle. Doing this maximizes the blood volume and increases your chances of actually catching the pathogen. But, and this is a massive but, you must never delay the administration of antibiotics while waiting for those cultures to be drawn or for any blood results to come back. Alongside the cultures, get a venous blood gas for that urgent lactate, plus your FBC, CRP, and LFTs.
Section 5. Urgent Management and Antibiotics.
When that clock starts, you need to move fast and execute the Surviving Sepsis Campaign Hour 1 bundle. Step 1, measure that lactate. Step 2, get your blood cultures. Step 3, hit them with broad-spectrum IV antibiotics. Step 4, start a rapid 30 milliliters per kg crystalloid fluid bolus if they're hypotensive or if that lactate is over 4. And Step 5, apply vasopressors if they remain hypotensive despite that fluid resuscitation.
I'm going to repeat this because it is absolutely the cornerstone of maternal survival. The administration of IV broad-spectrum antibiotics must happen within exactly 1 hour in women at high risk of sepsis. Your choice of empirical therapy should always be guided by your local hospital's epidemiology. If you don't know the organism and it's life-threatening, a combo like piperacillin/tazobactam or meropenem plus clindamycin gives you a really broad safety net. Just remember, you have to act within that golden hour.
Finally, Section 6, Fetal and Neonatal Care.
Amidst all this chaos, we really have to ask ourselves, as we're aggressively resuscitating the mother with massive fluid boluses and heavy-duty antibiotics, how do we safely manage the second patient? What's the risk of vertical transmission, and how do we monitor the baby through this massive metabolic storm?
Well, the guidelines are incredibly clear here. If you suspect sepsis during the intrapartum period, you need continuous electronic fetal monitoring. And you've got to be extremely cautious if you're even considering fetal blood sampling. Also, any baby born to a mother who got IV antibiotics for sepsis within a 24-hour window around the birth needs to be rigorously assessed for early onset neonatal infection. Oh, and a crucial point, if it turns out to be postpartum invasive group A strep, both the mother and the baby need to be treated with antibiotics proactively.
So, as we wrap up this explainer, I want to leave you with a vital challenge. Sepsis is sneaky. It loves to mask itself behind the normal physiological changes of pregnancy right up until the point of catastrophic collapse. As MRCOG candidates and frontline clinicians, the question is simple. When you're faced with a rapidly deteriorating tachycardic hypotensive patient, will you be ready to instantly think sepsis, call for that multidisciplinary help, and trigger the Hour 1 bundle? Your rapid response is literally what stands between your patient and those grim statistics. Keep this guidance fresh, stay vigilant, and definitely read through the full RCOG 64 documents so you're ready for whatever walks through the triage doors.